Medical pharmacology is often taught as a volume game. You are expected to ingest thousands of pages of drug names and classifications through sheer repetition. Relying on flashcard recall creates a significant vulnerability during a night shift. When a patient's condition changes at 3 a.m., the pressure makes it difficult to retrieve a name that was only learned by rote association. However, every neurological drug exists because of a specific physical breakdown. If we look at the brain as a biological machine, we find that clinical symptoms are the external indicators of internal mechanical failures. By mapping these connections, we can trace a path from the visible symptom back to its origin. This provides a framework to understand why a specific drug is chosen, rather than simply trying to remember that it was. When you identify the specific failure in the machinery, the pharmacological intervention follows a predictable logic. Consider a patient exhibiting a resting tremor, slow movement, and a mask-like, expressionless face. These symptoms indicate a dopamine drought. In the synapse, there isn't enough dopamine for smooth motor control. To restore movement, we increase available dopamine. We supply levodopa, use pramipexole to stimulate receptors, or introduce selegiline to block enzymes breaking dopamine down. Once the dopamine levels in the synapse reach a functional threshold, the patient's physical movement becomes fluid again. In another room, a different failure is occurring. A young patient reports sudden blurry vision, profound fatigue, and localized physical weakness. Here, the immune system is actively attacking the body. White blood cells are stripping away the myelin, the protective insulation for electrical signals. Because the system is attacking itself, the intervention requires a chemical ceasefire. We use immune modulators like interferon or glutathione to reduce these attacks, or steroids to halt a flare. Success in this case is measured by the stabilization of the nervous system. We are calming the overactive defense to prevent further structural damage. Now consider the cognitive decline in Alzheimer's. A patient asks the same question repeatedly, unable to retain new information for more than a few seconds. This occurs as the brain's communication network physically collapses. Acetylcholine is in short supply, while toxic plaques block remaining connections. To preserve the network, donepezil increases acetylcholine, while memantine shields surviving neurons from further decay. We are artificially supporting a failing network to slow the rate of cognitive loss. Clinical logic is crucial when encountering a diagnostic curveball. Imagine a stable patient who suddenly develops profound confusion overnight. Someone relying on a simple symptom-to-drug list might see the word confusion and assume the patient needs a chronic memory medication, but an overnight shift points to an acute physiological crisis, a sudden drop in oxygen, a systemic infection, or a metabolic imbalance. Correcting the underlying infection or restoring oxygen levels will resolve the confusion. This is the difference between drugging a symptom and identifying a cause. We have seen 3 distinct biological responses: restoring dopamine for movement, suppressing the immune system to save nerve tissue, and supporting acetylcholine to preserve memory. Every neuromedication is a functional tool designed to interact with these specific biological pathways. When you understand the pathway, the choice of medication becomes a clear extension of your diagnostic findings. Rote memorization provides a list of names. Pattern recognition provides a diagnostic map. One is a struggle to recall, the other a way to see. By focusing on the biological mechanics, you move past the data on the chart and begin to understand the actual physiological state of the patient in front of you.